conversation. And I was excited to hear you say that there was a lot of interest in this topic too, because I really feel like sometimes this can be such a taboo topic. Even people coming onto our program, how many times I've heard, don't tell mom and dad that they're on hospice. We don't want to use the hospice word, and I don't want it to seem scary. I mean, I know it's new, and it's okay that it's scary, but I hope at some point that we can all be more open in talking about death and what we want and what our wishes are, because my end of life goals and wishes are different than everybody else's. Um, so just a little bit about myself. I'm a nurse practitioner. I work in hospice in our home care. That's mostly my background. But then from 2019 to 21, kind of like the worst time to go somewhere else, right when the pandemic hit, I went over to neurology. My goal was to be in the ALS clinic. So I did that and worked with a lot of general neurology patients. And then in 21, I decided to go back to hospice, but I was able to stay in the ALS clinic, which has been absolutely amazing being on both ends. For our people in the ALS clinic that transition into hospice, they have me as a familiar face, and I'm able to go do home visits then and be a part of the team. So it was something that was kind of lacking in our program and on both ends. So it's really been an amazing experience. So I actually see we do 3 months in clinic. Every 3 months we see people, and then Dr. Erickson is our physician, and we alternate every 3 months. So it's just been a great experience. Uh-oh. So I just wanted to show you guys where I am. So this is our service area for hospice, since I know we have multiple states represented here on this call. So here's Minnesota, Wisconsin. Can you see my cursor as I'm moving it? Yeah, okay.
Yeah.
And so I am right here at the tip of Lake Superior in Duluth, and then I'm actually, that's where our main office is. I live here in Superior, and then we have an office up in Virginia and in Deer River, and then we see patients at 60-mile radius. So we got a huge net that we serve. Um, and then for our ALS clinic, we're the only ALS certified site north of the Twin Cities. So we serve Minnesota, Wisconsin, and we even have some people come over from Michigan. So I just wanted to start off with kind of the basics. What is hospice? So when Christy had reached out, we wanted to talk about kind of myth busting. So we'll go through some of those myths and then feel free to throw in any of your own at the end too if there's something that I miss. I think, there's a lot of misconceptions about hospice. So just in general, what is hospice? So it's a program funded by Medicare, Medicaid, and most private insurance plans have a plan to provide care for people with serious illness who have a prognosis of 6 months or less and want to focus on comfort and quality of life rather than pursuing aggressive care directed at a cure. So hospice is focused on person-centered care. So that is looking at the whole person. It's looking at treating symptoms, not just physical, but also any emotional, spiritual symptoms that may be distressing. Um, Emotionally, our emotional and spiritual health can definitely affect our physical health as well, and it all has to work together. Really, hospice, the medicine part that I do in hospice, is just a teeny tiny part of the whole big picture. The goal of hospice is to provide support and care for people who are dying of an incurable disease so they may live as fully and comfortably as possible. Um, and just what I was going to say too in the beginning of it being taboo, I know that I'm more blunt about talking about um, death, and that's something that I deal with every day in my work. But definitely in my personal life too, dealing with people, loved ones who have been on hospice. So I know that it is a hard conversation, so I don't want to discount that as well too. And I just sprinkled in a little things for levity in between these harder topics. So, just history, the first US hospice was in Connecticut in 1974, and then the Medicare hospice benefit wasn't created until 1982. So, I think that's crazy in my head. Like, it is still in the infancy. Like, we still have so much work that we can do and that we're going to do. I mean, I started on the floor at our hospice house as an RN in 2010, and um, I just think of the last 14 years, how much has changed in hospice and how much we've learned is just amazing. Just the concept of total pain and treating everybody, spiritual, emotional, physical health. I was born in 85, so the first Medicare benefit was only 3 years older than me, which is just amazing to me. Um, so it's not a concept that is new though. So it's from the Latin word hospice, meaning host and guest. It's the root word for Latin words such as hospitality and hospital. So back in 1095, it was called, the Pope called for the First Holy Crusade. It spurred people pilgriming to the Holy Land, and then they set up the hospice for care for ill and weary travelers. So definitely not a new concept. So the first myth we're going to tackle is it's a place. And I still hear this to this day. Actually, a couple weeks ago, a physician was referring somebody to hospice, and the patient was in an assisted living, and he said, well, he's probably going to have to move. And that is absolutely not the case. It's a philosophy of care versus a place. So we go to wherever the person is. So that can be someone's home, assisted living, group home, nursing home. We've had some people who have been homeless, and we coordinate with the homeless shelters. We literally have met people in the street with their medication, or bring them in to our hospice house to do a physical assessment. So we truly are trying to meet people where they are at and where they want to be. We want people to be where they want to be in their last days. At times I can say that might not be possible. So if we have someone at home and we're really struggling getting symptoms under control, and we've really maxed out what we can do, then we might need to have that conversation. Okay, we need to get you somewhere where we can get you different treatment to better manage your symptoms of pain or breathing. But we're really gonna fight and advocate to keep people where they want to be. Some people want to be at home. Some people absolutely do not want to be at home. And the right answer is whatever you guys want. We will do whatever. All right. So the next myth is hospice is only for people who are bedridden at end of life. And the simple answer is no, absolutely not. We want people referred earlier rather than later. There's a lot of different benefits to that. So not only helping the person coming onto the program, but it also helps the family. I'll come back to this here. So this was a study done in 2004 that they found that caregivers of patients who were enrolled in hospice 3 or fewer days had more major depressive symptoms versus somebody who was on hospice longer. So, to sum that up, people who are on hospice, their families are experience less depression, and are better supported. And that's a big thing with hospice is it's not just the person who has the disease, is treating the whole family unit. And that's something that with our folks living with ALS know very well, that it's not just a one person disease. It affects the entire family and the entire caregiving dynamic. And you need to support the entire community that you're in. So, and that's not just family too. That could also be if you're in a setting like an assisted living or a group home. So that includes the staff too. So, they can be, they need the support as well. And there's also no length or limit to the length of time and somebody can be on hospice. So, we have that general 6 months prognosis or less. I don't know how many times a day I say this, but we don't have the crystal ball to know when that 6 months is. I think if people who logged on first heard Amy say, death isn't on a schedule, we none of us know when our time is up. So actually looked up right before I came on here of I'm able to run a report of our patients, and the person who's been on our program the longest is 2.5 years. So they have to go through a recertification process. Once you're on the program for 6 months, then every 2 months you'll see a provider, and we have to do recertification through Medicare. But as long as we deemed that yes, if the disease follows its natural progression, death is likely within 6 months, then the person is still eligible for hospice. So, we have people that who are on the program for literally hours, and and then we have this person who's been on for 2.5 years, and everything in between. So another big myth that we're going to tackle is enrolling in hospice hastens death. So again, this is something I hear very commonly, that people think once they come onto hospice, we're going to stop all your medications and we're going to start an opioid, and then you're going to lay in bed and that's it. So and like I said, even in the medical field, I hear that a lot. So I know this isn't about heart failure, this talk, but I'll just take heart failure as an example. If someone's coming on our program and they have a lot of medications for their blood pressure and rate control and medication to help with the fluid, a diuretic is what it's called, and it's still appropriate for them to be taking it and they're still eating, up and about, we're absolutely not going to stop those medications. That's going to cause worsening of their symptoms and decreased quality of life. So we would never stop those medications unless it's a conversation with the person. And if it's, if say their blood pressure was too low and they were having falls, then we're going to have that conversation. For opioids, at least, and I can only speak to our hospice, but we do send out a little emergency kit of medications, and opioids are in that emergency kit, and that's for symptom management only. So we would never administer a medication when it's not appropriate if you're not having, we use it for shortness of breath and for pain. So those medications are there for rescue. And then I'm just going to go forward here. There's actually been a couple studies done. This one is a little older, but comparing hospice and non-hospice patients' survival. Actually, the bottom line of the study was that hospice enrollment did not significantly associate with shorter survival. And actually, the people that they studied, it was 29 days longer for hospice patients versus non-hospice patients. So what they did is from 1998 to 2002, they studied 5% of the entire Medicare population of hospice, and they did a retrospective analysis, and they were able to, so they did it for 5 different types of cancers and congestive heart failure. So they compared those people that were on hospice to the same diagnoses that weren't on hospice, and they found that it did not associate with shorter survival. So I think that's very reassuring that, that's not our goal, is never to hasten death. And one thing I did want to say too is I hear a lot, I didn't write a slide for this myth, but I hear a lot with people say, well, there's nothing more we can do. And so they put me on hospice. And I always stop that conversation and say, there's always something more we can do. It's just the shift, the focus is shifted. So, for someone coming on with cancer, there's nothing more we can do. Well, they're saying there's no more chemotherapy or radiation that can be done, but we can always focus on aggressively treating symptoms. So we're going to focus on quality of life and what that means to that person and what makes life meaningful. So another myth is once you enroll in hospice, you cannot come off the program. So nothing is written in stone. You are still in charge of your healthcare no matter what. And what your goals and wishes are. And that doesn't mean that you make a decision and you can't change your mind tomorrow. Um, so if so I'll give the example. I was on call a couple weeks ago. I got a call that this gentleman, the facility called the ambulance, and he was in the emergency room. They found out he was septic. His wife wanted, it was his healthcare agent, and she wanted more aggressive care. So at that time, she signed a paperwork to revoke off of hospice, is the term. So at that time, she signed a paper saying, I don't want hospice anymore. And then he comes off of the hospice, and then they can pursue aggressive care. And then at that time, his insurance, that he had prior to hospice, resumes without any interruption. Um, so we don't feel bad when people revoke off a hospice. We don't get mad when people revoke off a hospice. Hospice is a choice, and it's that extra layer of support in the home to help with people's comfort and their goals. So if somebody wants to have more aggressive care, then that's 1,000% what we want that person to do. And there's no limit of how many times a person can do that. We may have that conversation if someone's coming off and on, every week. Are you sure you want our support? Is this something that you want, or do you want to be able to always pursue aggressive care? But like I said, it is a choice. Another myth, hospice is expensive. If you are eligible for Medicare or Medicaid, there is absolutely no cost to enroll in hospice. It's a benefit that we have through Medicare. And most private insurances also have a hospice benefit that covers most of the cost of hospice. And this next slide here is everything that is covered under hospice. And again, it's nothing out of pocket for someone who's on Medicare. So there's 24/7 access to hospice nurses and other hospice team members. So that doesn't mean that there's 24/7 care. There's some coverage, with home health aides, volunteers, nurses, but the 24/7 hands-on care is not something that hospice provides. Equipment such as electric bed, over-the-bed table, walker, wheelchair, oxygen, bedside commode. This is where it gets kind of tricky when it comes to the ALS clinic is, we want to make sure those bigger items that we know that are going to be needed, such as like a power wheelchair, are completed before coming onto hospice, because that's just not something that hospice can cover. Any medications related to the terminal prognosis is all paid for by hospice. Palliative procedures, if related to the terminal prognosis. So example for that would be somebody, say, for a cancer diagnosis, and they end up doing palliative radiation for pain. That's something that would be covered under hospice. There's a social worker on the team to help work with financial concerns, advanced care planning, transitions, and counseling. Physical and occupational therapy evaluations are available. Usually don't do like restorative treatments or sessions, but available to help for safe patient transport, comfort, things like that. There's a spiritual care coordinator on the team to help support patient and family with spiritual concerns. Absolutely does not need to be a certain type of denomination, anything like that. Just wherever the person is at and where they are at. Sometimes someone just needs someone to talk to, and that would be our spiritual coordinator. Does not need to be about God or any certain denomination. We have a music therapist on our team who is absolutely amazing. Some hospices have a massage therapist. Unfortunately, we don't at this time. We had the ball kind of rolling before COVID, and then it kind of got waylaid. So that's something hopefully we'll get back to at some point. There's a certain percentage, and I'm sorry, I don't remember it off the top of my head, of volunteers that we need through the benefit to be able to be a hospice. And they are amazing. Our volunteers are absolutely amazing. We have they read, they write letters, they give the caregiver a break. They can't do any hands-on care, but they certainly can be present if the caregiver needs to run an errand, take a nap, anything like that. Just someone to sit with, chat with, play cards with. We have home health aides to assist with personal hygiene. And then we also have bereavement who support family through the grief process for 13 months after death, which has been so beneficial for many people. And that 13 months helps get you through that tough first year of birthdays, anniversaries, Christmas. And then if more therapy or counseling is needed afterwards, they can help find you that avenue. So this is and notice the patient family communities in the center. It is driven by you guys, the patient. I also say the nurse manager is kind of in there too. I would say right there with the patient, just kind of help navigating and making sure everybody's on the same page. Um, so we are a non-profit hospice, and for we're a little bit different than we have our own medical providers. So which is really nice because our nurse calls us and they get us right away. We're on 24/7. We're able to change orders, and of course we specialize in hospice and palliative care. So we are more aggressive with symptom management than somebody like a family practice doc. Another myth that we're going to tackle is DNR code status. So DNRs do not resuscitate. There's absolutely nothing in the verbiage with Medicare that the hospice benefit that there's a requirement of being DNR. And I would say we have about, 300 patients on our program right now. I would say maybe 4 or 5 of them have a full code status, and it is 1,000% okay. It gives us opportunity to continue to have conversations and making sure that they're getting the care that they want. So I'm not going to go through all this. This is just the basic criteria for ALS for hospice. I would say when it comes to, and I get this question a lot in clinic, give me a time frame. What are we looking at? And I always say that I think I've said it twice already in this half hour that we don't have that crystal ball. But I would say looking back at your last 3 to 6 months is a good predictor of what your next 3 to 6 months is going to look like in terms of decline. So, coming um, we have decline with function, but also either some impaired breathing or impaired nutrition. So I wish I had like a slide there for levity. So just a quick hospice versus palliative care. Philosophy of care is exactly the same. There's a team approach, person-centered care, and again, looking at the physical, the psychosocial, physiological, social, and spiritual aspect of the person. Hospice is for patients, and we already talked about this, who wish to forego aggressive treatment with a prognosis of 6 months or less. So hospice technically is palliative care, but palliative care is not hospice. I know that is a confusing topic. So I just wanted to give a little example about coming on both sides of the ALS clinic and then being in hospice. So I was working with a man with ALS who he was diagnosed in July 21, and he had been experiencing weakness and dysarthria, which is kind of slurred speech, for about a year. At the end of December of 21, he had a feeding tube placed for difficulty swallowing. He was malnourished. Shortly after, he was admitted to the hospital for weakness. Prior to hospitalization, the family started to look for placement, meaning in a skilled nursing facility, and they were really struggling in finding a place that they wanted him to go to. And it can be difficult. People living with ALS, that there's a lot of complex care needs that you have. So at that time, he was transferred from the hospital to our Solvay Hospice house as a resident. So that was in January. And I just briefly put in his qualifying symptoms. His FVC, which is a pulmonary function test, was 10%. He had a decreased function. He had difficulty being understood with his speech. He needed to take all his hydration, nutrition pretty much through his tube, and he needed help with all his cares. So this is just my levity in between here. So I just want to show you our beautiful hospice house. So it's a 12-bed house in Duluth. It's a home-like atmosphere, and we do inpatient, residential, and respite care there. Um, we have served a lot of different populations. American Indian population is higher around here, so we've had people who've done smudging. Um, a lot of different ceremonies. We have woods out back, so many times like animals are bedding down by the patient's rooms. It's really amazing. Actually, my husband's grandfather passed away there, and on the day he died, there was a buck and a doe that bedded down right outside the window. So it was absolutely beautiful. So um, not that I'm plugging Solvay, I just wanted to show you guys what I was talking about and how beautiful it is. Um, So back to my example. So some family comments that when this person was admitted to the hospice house where he is in nowhere ready for hospice, but this is the nicest place for him to be. We're just using this for a place for him to stay. So if we go back to here, his qualifying symptoms, and then we know, oops, that was way back there. I don't need to go all the way back there. Then we know from the criteria that he absolutely clinically qualified for hospice. But being clinically ready for hospice and being emotionally ready for hospice is 1,000% a different story. So I was so thankful that he was enrolled in hospice though, because we were able to give him the time and the attention that we just really weren't able to do in our ALS clinic. Because first of all, we were able to go to him and our entire IDT went to him. I can't tell you how many family meetings we have where IDT was present, so that our spiritual care coordinator, our social worker, myself, most of the time an MD was with me, and then the skilled nurse, and then of course the patient and family. So biggest thing is we wanted to talk about goals of care. He clearly stated he did not want to be hospitalized again. Um, and again, he did not have to leave the building. He received those family meetings there. The RT was able to come to him to help with the AVAP setting. He used oral suction. Um, he had multiple visits from our physical therapist. He had got a new Tilton space wheelchair. Lots of teaching to the staff. They set up a home exercise program for him, and then we had the speech therapist up there to help him with his eye gaze machine. And what's really nice with our program is we contract with the same um, therapies as our ALS clinic. So again, that we had that continuation of care. So he had the same PT, OT, and speech therapist all the way through. He had regular skilled nursing visits. He had a volunteer that he really connected with up at Solvay, helped him with day-to-day tasks. I would say the biggest thing with him is he had visits from his regular priest, but then he also had his chaplain visits, and I think they had a really special bond. I asked our chaplain about it after, when I was making this, and he said that he didn't want to focus on the disease. He didn't want to talk about losses. He wanted to talk about what he's gained. He knew and this man was very intelligent. He needed his conversations to be very intellectual, stimulating. We also had home health aides that came up to Solvay, even though there's 24/7 care there, just to give that extra TLC, give him extra range of motion, and give him extra walks through the atrium. So in August of 22, he started to decline. He actually had a complication that was not related to ALS. Again, had family meeting, made sure what his plan of care was, and he did not want to pursue aggressive care. And he passed away very peacefully with his family by his side, and the family has followed for 13 months. So even though this is a very sad situation. I think we truly made it the best it could have been. We really, this man was able to still do a lot of work, and be with his family, and we know that we followed his goals, till end of life. So this is Cicely Saunders. She was actually the founder of that modern hospice movement, from the 70s, and we use this quote all the time, and I just think it's beautiful. At the end of the day, you matter because you are you. You matter to the last moment of your life, and we will do all we can do not only to help you die peacefully, but live until you die. And that living until you die is whatever that means to you and whatever is important to you. And if I have any advice for anybody, is, whether, you're a family member watching this, or someone that just stumbles upon this, or somebody who has faced a difficult diagnosis, is, doing a healthcare directive. Um, I think that is just so important. And I know we offer advanced care planning. I don't know if other programs do, but it's something that I think that, you need to have that conversation often, because our goals change through time. I have a healthcare directive. My goals right now as a 38-year-old with two small children could look very different in 30, 40 years if I were to be facing something, that I'm not facing now. So, I just that conversation needs to be ever evolving and include your care team and your healthcare agent. Um, so again, I hope this wasn't too heavy. Let's see, how did I do on time? So I definitely want to open this for questions. And Amy, I don't know